A hernia is when an organ protrudes or bulges out through the body wall that normally contains it. So, an abdominal wall hernia is when an organ protrudes through the abdominal wall, which is made up of a few layers. The deepest layer is the visceral peritoneum, which covers many of the abdominal organs and lines the peritoneal space. That layer wraps around to form the parietal peritoneum. Then, moving outwards, there's the extraperitoneal fat, the transversalis fascia, the muscle layer with the internal and external oblique and transversus abdominis aponeurosis, and a layer of fascia, which has different names in different regions. Anything that increases the pressure of the abdominal cavity may result in a sac that forms in the abdominal wall through which organs may protrude. The organ that's usually involved in a hernia is the gastrointestinal tract, but it can also involve other organs like the omentum, the bladder, and even the ovary. Abdominal hernias vary in size and location. Small hernias can be asymptomatic, or they can cause pain and create a small bulge that can worsen with increased abdominal pressure from coughing or straining. Over time, hernias can grow and lead to bowel obstruction, causing severe pain, nausea, vomiting, or constipation. Larger hernias can put pressure on the overlying skin, causing erythema and ulceration. Generally speaking, there are 4 types of abdominal wall hernias: groin, ventral, pelvic, and flank hernias. The most common type are groin hernias, and they occur at the lower margin of the abdomen where the thigh meets the hip. Groin hernias are classified into inguinal and femoral hernias, and inguinal hernias are further classified into direct inguinal and indirect inguinal hernias. Direct inguinal hernias protrude medial to the inferior epigastric vessels within Hesselbach's triangle, which is formed by the inguinal ligament inferiorly, the inferior epigastric vessels laterally, and the rectus abdominis muscle medially. Whereas indirect inguinal hernias go through the inguinal ring and protrude lateral to the epigastric vessels. Femoral hernias are inferior to the inguinal ligament and protrude through the femoral ring. Risk factors for groin hernias include a prior hernia, old age, chronically increased intra-abdominal pressure due to chronic cough, constipation, or strenuous exercise, abdominal wall injury, and smoking. Most of the time, a groin hernia causes a dull sense of groin discomfort with strain or lifting, which is relieved once the pressure is removed. Femoral hernias in particular can be an emergency if the bowel tissue gets trapped or incarcerated and the blood vessels get strangulated, leading to bowel ischemia. Next, there's ventral hernias, which occur in the anterior abdominal wall, and there are a few types. First, there are epigastric hernias, which are defects in the abdominal midline between the umbilicus and the xiphoid process. They're due to a weakened linea alba, and most individuals have a small, slightly uncomfortable lump between the umbilicus and the xiphoid. Second, there are umbilical hernias, also called periumbilical hernia. This is a ventral hernia near the umbilicus, and it's often associated with pregnancy. In males, umbilical hernias can often get incarcerated, whereas in females, the hernias are often easy to reduce. Third, there are Spigelian hernias. These occur through a defect in the Spigelian aponeurosis, which is the aponeurosis of the transverse abdominal muscle bound by the linea semilunaris laterally and the lateral edge of the rectus muscle medially. The typical location is in the Spigelian hernia belt, a transverse 6 cm wide zone around the level of the arcuate line, which is the caudalmost extent of the posterior rectus sheath. Individuals usually have tenderness and swelling in the mid to lower abdomen, just lateral to the rectus muscle. Fourth, there are incisional hernias which develop where a prior surgical incision was made and the fascia never fully healed. Since most abdominal incisions are made in the anterior abdominal wall, most incisional hernias are ventral hernias. Risk factors for poor healing include smoking, diabetes, old age, obesity, malnutrition, immunosuppressive therapy, and connective tissue disorders. Incisional hernias typically develop in the early postoperative period, but can sometimes occur even years after surgery. Pelvic hernias protrude through one of the pelvic foramina, so obturator and sciatic hernias, or the pelvic floor, so perineal hernias. Obturator hernias are rare, and they occur when there's protrusion of the abdominal organs through the obturator foramen, which is on the anterolateral aspect of the pelvic wall, where the obturator nerve, artery, and vein traverse. Weakness of the obturator membrane can cause enlargement of the obturator canal, with a defect that is usually anterior and medial to the obturator neurovascular bundle. Preperitoneal fat and lymphatic tissue in the obturator canal normally form a cushion around the neurovascular bundle that prevents herniation. Thus, obturator hernia usually occurs in the setting of profound weight loss. An obturator hernia can cause obturator neuralgia, which is groin pain that radiates medially to the knee due to compression of the obturator nerve. An obturator hernia can also cause a proximal thigh mass to form between the pectineus and adductor longus muscles, or ecchymosis of the thigh if bowel necrosis has occurred. Next are sciatic hernias, which occur when abdominal contents protrude through the greater or lesser sciatic foramen. The risk for a sciatic hernia increases in individuals that have had pelvic surgery. These unusual hernias can cause a buttock mass, abdominal pain, or sciatica symptoms. Finally, perineal hernias are the protrusion of organs into the perineum through a defect in the pelvic floor. Perineal hernias typically occur in older multiparous females or occurs incisional hernias in individuals with extensive pelvic operations. Perineal hernias cause a unilateral bulge in the area of the labia, perineal regions, or gluteal regions. Finally, there are flank or lumbar hernias, which are when there's a protrusion of organs through fascial defects in the posterolateral abdominal wall. Lumbar hernias arise in one of two possible triangular defects in the lumbar region. The superior lumbar triangle, also known as the Grinfeld triangle, is bordered by the 12th rib superiorly, internal oblique laterally, and quadratus lumborum medially. The floor is the transversalis fascia and the aponeurosis of the transverse abdominis muscle. The roof is the external oblique and latissimus dorsi muscles. The inferior triangle is also known as the petite triangle because it's a small triangle located between the posterior border of the external oblique muscle laterally, the lateral border of the latissimus dorsi muscle medially, and the iliac crest inferiorly. The floor is composed of the lumbodorsal fascia, continuous with the aponeurosis of the internal oblique and transversus abdominis muscles. Lumbar hernias can form due to trauma or surgery. The most common presentation of a lumbar hernia is a palpable posterolateral mass that increases in size with coughing and strenuous activity. The mass is usually reducible and disappears when the individual lies down. Lumbar hernias can cause vague back pain, bowel obstruction, urinary obstruction, or develop into a pelvic mass. For diagnosis, the hernia and the edges of the defect may be identified through palpation while a person is standing and lying down. Reducible hernias can be pushed back into the abdomen by putting manual pressure to it. Irreducible or incarcerated hernias are trapped within the hernia sac such that they cannot be reduced. Over time, an irreducible hernia can cause blood and lymphatic fluid to get trapped, leading to swelling of the trapped tissue. As edema accumulates, the impairment becomes more and more severe until the contents of the hernia sac can become ischemic and eventually necrotic, which is referred to as a strangulated hernia. Reducible hernias are also called uncomplicated hernias, while both irreducible and strangulated hernias are considered complicated hernias. Sometimes, very small hernias, hernias in obese patients, and hernias in certain locations like pelvic or lumbar hernias require imaging studies like an abdominopelvic CT scan to get diagnosed. The definitive treatment for hernias is surgical repair. There are two different types of surgical hernia repair: herniorrhaphy and hernioplasty. Herniorrhaphy involves making a long incision directly over the hernia to access it. The herniated tissues are then pushed back to their original location. The hernia sac of the abdominal wall is removed, and the edges of the healthy muscle tissue are pushed together and stitched. Hernioplasty is a type of hernia repair surgery where a flat sterile mesh patch is placed over the weakened muscle opening and then stitched into the surrounding tissues, which keeps the mesh in place as reinforcement for the weakened muscle tissues. Hernioplasty is better known as mesh or tension-free hernia repair. Mesh repair is performed in most cases since it has a lower recurrence rate, while non-mesh repair techniques are primarily used when mesh placement is contraindicated, such as when there is active infection or necrosis of the herniated tissue, or when the use of a mesh is cost-prohibitive. Reducible hernias that are asymptomatic can be managed with watchful waiting while monitoring for complications like bowel obstruction or strangulation. Symptomatic hernias can be managed with elective surgical repair. Individuals with an acutely incarcerated or strangulated hernia typically require urgent or emergency surgery depending on the situation. Alright, as a quick recap. Abdominal wall hernias are classified by location into four kinds: groin, ventral, pelvic, and flank hernias. Small hernias can be asymptomatic or cause pain, where large hernias typically cause a bulge in the abdominal wall. Over time, hernias can lead to bowel obstruction and can put pressure on overlying skin, causing erythema or ulceration. For diagnosis, the hernia should be felt with the individual standing and lying down to see if it can be reduced and if there's evidence of incarceration or strangulation. Small hernias, hernias in obese patients, and certain anatomical locations like pelvic or lumbar hernias require abdominal pelvic CT scan. The definitive treatment of hernias is surgical repair with herniorrhaphy or hernioplasty. In herniorrhaphy, the herniated tissues are pushed back to their original location, and the edges of the healthy muscle tissue are pushed together and stitched. In hernioplasty, a flat sterile mesh patch is placed over the weakened muscle opening and then stitched as reinforcement. Symptomatic hernias can be managed with elective surgical repair. Individuals with an acutely incarcerated or strangulated hernia typically require urgent or emergency surgery, depending on the situation.